Yeah, so despite the recent advances in treatment of non-muscle invasive bladder cancer in the BCG refractory state, we still have gaps. I mean, a lot of patients don't respond, or the duration of response is not as high as we want to. So I think we're still trying to see whether we can do combination therapy of these drugs to see whether we can improve the efficacy and also the duration of response of these medications. So Adstiladrin, Nadofaragene Firadenovec, has been approved for use in the BCG-Unresponsive space. It has fairly good efficacy, 53% at 3 months, but there's a drop-off in its efficacy over 1 year, up to 25% of patients remaining in complete response at 1 year, and even lower when you look at 3 years. So it's an effective drug. It's very well tolerated. So now we want to see whether we can combine it with additional therapies to see whether we can improve that outcome. So that's really the motivation behind this trial. Yeah, so the mechanism is very different, right? So you want to pick, I think, 2 different types of mechanism of action to be able to achieve your cell kill and also duration of response. So we're taking sort of a broad approach and combining it with chemotherapy or immunotherapy. And then part of the trial is also looking at reinduction, which was not done in the CS003 study. So the 3 arms are nadofaragene alone, nadofaragene with chemotherapy, specifically gemcitabine and docetaxel, and then the 3rd arm would be pembrolizumab as the additional. So each one of them has nadofaragene. So it's a randomization of 2 to 2 to 1 with nadofaragene plus pembrolizumab. And we picked gemdosi because that's currently off trial, one of the more commonly used agents. And so we're trying to see whether we can improve with either chemotherapy or checkpoint inhibitor. Yeah, we're hoping to improve bladder preservation rates with this approach. So like I said, with the original trial, the CS003, a reinduction was not allowed. But if you look at all the current trials, reinduction of all the sort of immune modulator, immune-related type of responses is allowed, and it makes sense, but makes biological sense. We've been doing it with BCG for a long time, and now with gene therapies and other viral vectors that are introduce certain genes into the cell. Makes sense that you need longer duration. So we're hoping to see improvement in the nadofaragene alone arm with reinduction, and then with the chemotherapy arm and the immunotherapy arms see improvement in outcomes, and therefore reduce the need for a cystectomy in the future. Yeah, absolutely. I mean, there's always that balance, right, between efficacy and treatment-related adverse events. Fortunately, with nadofaragene alone, we've seen very few toxic, and this is a very well-tolerated drug, both in the trial and also in practice, as we've seen it's in its commercial use. We don't think there's going to be synergistic adverse effects. So we know very well what the adverse events of gemcitabine and docetaxel are. Most of them are irritated voiding symptoms, but we're not really sure. There's a possibility of having increased adverse effects. We're not sure. But we think with the low toxicity profile of both drugs, even when you combine them, it should hopefully be tolerable. Now, the addition of the immune checkpoint inhibitor to any therapy, of course, is going to increase your AEs. And that's well known. I don't think throughout any trial in any of the either bladder cancer or any other disease states we're going to find anything new. So we sort of will expect the usual systemic toxicities that we've seen with the immune checkpoint inhibitors. Yeah, absolutely. I mean, that's the holy grail, right? We're trying to individualize treatment options for patients, and these are all exploratory. We need to find out who responds and who doesn't respond, and we do currently we know the mechanism of action, but we really are not sure how these translate in the patients. So most of the studies are going to have these secondary endpoints of exploration of biomarkers, usually in the urine, but some serum as well. But we'll hopefully learn more in the future as we start to try to personalize the treatment options for the patients. Well, first we're starting in the U.S., but the plan is to go global, make this a global trial.